Welcome to the Men's Health Unscripted podcast with Patrick and Cam.
Where we focus on your entire health, mental, physical, spiritual, and emotional to make sure you are good to go every day.
What's going on, guys? It's Patrick. I'm here with Dr. Sasson. He has an extensive medical career, but today we're especially going to talk about GLP-1, so the weight loss drugs. And if you've been following the podcast for a while, you probably know that our perspectives on GLP-1s have changed quite a bit over the years. I guess when they were out and new, we didn't really know a whole lot of information about them. And now that they've been studied more, we have a lot more data. And I think they're not quite a wonder drug, but they're pretty amazing, right?
I'd go with wonder drug.
Yeah, you would say so.
Mm-hmm.
As you guys probably know, I've gotten into compounding in my career. And so peptides have become a big part of my life, really, to say the least. So, Dr. Andre, tell us a little bit about your background. It is extensive. We had lunch the other day, and Dr. Andre's got a great story. Tell us a little bit about your background and kind of then maybe how you transitioned into weight loss.
Yep. Well, hello. I was born and raised in Venezuela, moved to the U.S. when I was a kid, middle school, high school in Miami, college in Boston at Tufts University. Then I did like a Peace Corps type of thing. I did Teach for America, taught in the ghetto. Did that for a couple of years, transitioned into medicine. Then I went to medical school, GW, George Washington Medical School in Washington, D.C., where I then decided to become an ER doctor. So I did my residency, my specialty training in emergency medicine at the University of Chicago. Finished that, have been in practice altogether over 20 years as a ER physician. I still work as an ER doctor now. I worked yesterday, I work tomorrow. I've also, for 15 years in emergency medicine, been core faculty, meaning I train young doctors to be ER doctors. For most of the past 15 years, I've been the chief of my emergency department. In some of the past 10, 15 years, I've also been involved in various business ventures. I've owned my own CrossFits, had online CrossFit store, I've a caffeinated chewing gum company. But what happened with the GLPs was that year and a half ago, 2 years ago, my sister and I challenged each other to lose weight. She got divorced. She wanted to lose weight. So we did what she's a Duke MBA. And we did what two type A brothers and sisters do. And we put money on it. We bet, right?
Sure.
So what happened? At that time, I'm in my early 50s. She's in her 40s. And nobody wins. It's hard to lose weight. And we're type A. And we were going to the gym. It just wasn't working. So she found semaglutide, lost a bunch of weight, made fun of me, made me pay up. And then I got interested, but I'm a physician, I'm a nerd. I wasn't just going to start taking them. So I decided I would read up, and I did. And I was intrigued. So I started tirzepatide, lost 40 pounds. Then my friends, particularly ones I play sports with, were like, hey, what happened to you? Because you look different, right? After 40 pounds. And when I would tell them what I had learned, with excitement, like, these are remarkable medications, they'd be like, well, hook me up. Can you prescribe for me? And I was like, yeah, I'm not that kind of doc, because I'm an ER doctor. And at the time, too, not only I was actually the chief of emergency medicine of a big program. I had 120 providers, most of them physicians, working for me, covering 7 emergency departments. I had become the medical director for our county's EMS system. So I had a lot going on. And I was like, yeah, no. But eventually I did it for a couple of friends. They become walking billboards. I have found it to be so amazing for me personally, and so gratifying to help people on this weight loss and wellness journey, because it's both. It's weight loss and wellness. That I actually gave up. I resigned my position running the big ER group to do Lighthouse Weightloss.
Right. And it makes sense, too, because you're seeing, the emergency room isn't always the best place to see success, right? I mean, you see it, but generally they come in, they're pretty banged up. They're suffering from some type of issue. Well, you got to patch them up, see if they can be admitted. But here you can really stick with the patient, track their success, be their biggest cheerleader, and impart part of your journey onto their journey, mm-hmm. and just help guide them through. So I can see where it's, it could be more gratifying. ER
is cool too, but we're talking about polar opposites of the healthcare spectrum, like ultimate and acute disease management versus wellness.
Yeah, and potentially keeping people out of the ER, right? You're losing weight, you're
Yep.
lowering your CV risk.
Right. So
right.
let's double click on that for a second,
Okay.
because I think people have a good sense that these medications work for weight loss.
Sure.
And no doubt, I mean, they're remarkably effective for weight loss. But I find that a lot of people really aren't clear on the health benefits. So although these drugs have been around for a while, longer than most people think, these medications, the GLPs, were developed in the 1990s. And they've been mass marketed now for quite a few years, and there are tens of millions of people on them. The health benefits, the literature on the health benefits has been really the last year, 2 years. And I would say there's never been any class of medications that has shown this level of health benefits. So the biggest are, and this is from like legit high level medical literature, right?
Right.
This is a 20% reduction in cardiovascular events, heart attacks, things like that, a reduction in stroke risk, a reduction in your risk of dementia, a reduction in your risk of getting kidney disease, in your risk of progressing to diabetes, even your risk of osteoarthritis. Basically, that's come out. So will you lose weight? Will you look better? Will you feel better about that? Yes. But with that comes down the road massive health benefits. So what I tell my patients is, yeah, I got on them for the vanity. I wanted to be thinner,
Right.
but I'm staying on them for the youth.
Sure. And now, okay, so now we kind of have to circle back again. So we've been talking about GLP-1s. Let's clear it up a little bit. And we'll probably mention the name brands once and then we'll let it go. But semaglutide, you're thinking Ozempic, Wegovy. Tirzepatide, you're thinking Zepbound, Mounjaro.
Right.
And that'll be, we'll leave it at that.
So to clarify, the drugs themselves, there are many GLPs have been made. There are 2 that have mass market presence.
Right.
They are both once a week injections. The one that got the most attention initially, semaglutide, the one that came to market first, is marketed or trademarked as Wegovy and Ozempic. The newer one that's more effective, tirzepatide, is marketed by its manufacturer as Mounjaro and Zepbound. So tirzepatide, Mounjaro, Zepbound, that's essentially, they're all tirzepatide. And then semaglutide, Ozempic, Wegovy, they're all semaglutide.
Right. What exactly do they do in the body, right? Like people know, oh, I just take this shot once a week. That's what I hear as a pharmacist, right?
Yeah. I
take this shot once a week. I do this sublingual thing. Those are the things that I hear.
Yeah.
And so what exactly are they doing in the body to elicit all of these benefits?
So I think you have to start by recognizing that your body makes them.
Right.
We make GLPs. So like if you're sitting down and having a meal, your gut's got to tell your brain, okay, I've had enough. I mean, there's really only 2 ways an organ communicates with another organ, right? Like brain can send an electrical signal through a nerve, but organs communicate each other through chemical signals in the blood,
right.
hormones. So your body makes a GLP hormone. We call them incretins, but they're really it's a protein or peptide chemical signal. So these are synthetic versions of that have been the real science. The breakthrough was how do you make them last a week?
Right.
Because the ones that we make, they last 5 minutes. And it's a whisper, right? The easiest thing in the world is to overeat, but we're getting that signal. It's just easy to ignore. So first of all, just know you're making them. So now when you take additional GLP beyond the ones you make, that's going to last a week. Those drugs are having 3 major mechanisms of action, probably more, but 3 well-described mechanisms of action. The first is what they were developed for. So these medications were developed by a diabetes company as a diabetes drug. It was only incidentally, unexpectedly, that they found that they lowered weight.
Right.
So they're really good at helping your body in how it handles sugar, related to your insulin production and your insulin, how the cells respond to insulin or insulin sensitivity. So it helps you metabolize sugar better. That doesn't mean you can eat more sugar. It doesn't mean that you're gonna you're not getting calories from sugar. It's how it's handled, how it's in the blood. So everybody benefits from decreased sugar levels in their blood, whether you're diabetic or not. For example, that's the mechanism for why you don't have as much dementia, because you don't have as much sugar in your blood.
Right.
So that's mechanism 1, the diabetes one. Then they're also a satiety or a fullness chemical signal to the mind. So the drug goes to your brain and it's a chemical signal to your brain that you're not hungry. And that's what you hear people talk a lot about: food noise or loss of appetite. It's a chemical signal. The same one we make just lasts longer.
Right.
And we control the volume because you control the dose.
Right.
In addition to having a chemical signal that you're full, the other mechanism that kind of works hand in hand with that is that it slows the transit of your entire GI system. So when you have a meal, put some food in it goes in your mouth, esophagus, stomach is in your stomach, and it stays there for a bit of time while the stomach does the stomachy things, an hour or so, and it goes on into your guts. When you take these medications, it's going to stay in your stomach a lot longer. So you are simultaneously getting a chemical signal that you're full, but you are actually physically full longer. And the combination of those things leads to people eating less and losing weight.
Ultimately losing weight. And when I first heard about it, I think we were in pharmacy school and we were getting the lecture on the GLP-1s, and none of the additional benefits I think had really been known yet, except for weight loss. And they're like, oh yeah, this Ozempic thing, like people are losing a bunch of weight on it. Like that was pretty much what one of the professors said. And they're like, could be big.
Like Viagra.
Right.
Hey, the patients we're giving this blood pressure medication to are reporting increased performance. Hey, it was an unexpected. It was unexpected in rats. The rats were losing weight, and then even more unexpected that it translated to humans.
Right. It was just interesting, like hearing it, and then you start seeing commercials, and you're in school, out of school, now you're in the system. You see the commercials, you're like, oh, okay, wow, there's really definitely something to this. And then being in America, we can just mass market it and really get it out there. And it's good and bad, right? Like it's a controversial topic just to get on advertising a little bit, right? With something like this, to let people know that there's an option out there for them that can make them healthier, great. Some of the other advertising, oh man, it's kind of almost seems predatory at times.
What do you mean?
Just as far as like the mass pharma advertising.
In general or GLP specific?
No, in general. Like mass advertising, mass advertising like drugs that 98% of the population would never know what they're for or what they do. Here's a drug. It's kind of controversial,
here's a drug that's
right?
beneficial to potentially like half of adults.
Right. And then, but now you have these where it's like, wow, you can lower your CV risk. You can reduce your risk of diabetes. I've seen people reverse diabetes using these tools. And when I first started to see the weight loss benefits, I was like, wow, these could be such a great tool for someone who has a horrible lifestyle, right? It's so hard if someone is completely sedentary, 98% of their calories comes from processed foods, to get up and, feel good enough to start doing something where.
You should mention that, because here's what I see with my patients. You could sort of group the two basic categories: people who want the medications just to eat less, and then people who view this as a component of a healthy life reboot. And I get that quite a bit. I said, I want to start this medication to kickstart, and then they want to do some of the adjuncts. The people, in my experience, the people who use this as part of a more global campaign around wellness, do better, do the best.
Of course, right? Like
naturally.
The well eventually could run dry, right? You stop doing it if the diet lifestyle has not been altered at least a little bit. Yeah. The results are worse, and the rebound weight gain is potentially worse.
But the thing is that the fact that they're so effective is both the best and the worst thing about them, right? Because in the past, let's be real, if you wanted to lose weight before GLPs, let's say you went to a physician weight loss clinic 5 years ago, what did it look like? They'd throw everything at you. You'd have a physical therapist, you'd have a personal trainer and a nutritionist, and maybe even a counselor to talk about mental health. And they look at your sleep hygiene. And why would it have to be such a multimodal approach? Because nothing really works very well by itself.
Right.
Now you have a single modality, which if you do nothing else, is going to give you between 15 to 20% total body weight loss. So that means that a lot of people don't have to do any of the things. But clearly, I think we're on the same page. If you want the best results, this is a phenomenal tool to jumpstart entry into a wellness journey. And even if you don't mean to, I find a lot of patients do, meaning they just wanted to have weight loss, but then they're successful. They look better, they feel better, and they become more interested in other dimensions of weight loss. Other dimensions of health and wellness.
Right. I think something else to notice too is that what we've seen with some of the GLP-1s, which I find fascinating with GLP-1s and other peptides, is there's an anti-inflammatory benefit.
Right. Right.
And I just wanted to dive into that for a second, like what we're talking about, getting somebody's weight loss journey kind of kickstarted, but you feel better because your joints don't hurt as much, right? Potentially with the anti-inflammatory.
So just to be clear, I think, remember when you asked me about mechanisms, I said 3, maybe more.
Right.
So opinion now, like I want to be real clear about what's high quality medical literature, what's opinion. Opinion is I think there may be more at play here than just the mechanism we discussed. For example, there really is some good idea that it has something to do with the reward center, because recent studies came out that that people who want to cut back on alcohol, this is helping with people to drink less.
Right.
It's being studied for like gambling. So there's something to do with these medications. I don't think it's fully mapped out. And then the other thing, the inflammation, I think if you wanted to look at the health benefits in general, I would break it down into 2 categories, short-term and long-term. And if you look at long-term, basically all the diseases that you're more likely to get if you're heavier, you're less likely to get with these medications. And is that just weight loss, or is it also anti-inflammatory? I suspect you're right, but those mechanisms are not fully elucidated. But there's good hints. For example, statins, we talked about statins previously. My understanding is that a lot of the benefit from a statin is not from the cholesterol lowering, but from the anti-inflammatory. I think inflammation is a huge and fascinating topic. And it may be that these medications are decreasing. Probably just losing weight alone makes you less inflamed.
Right. There aren't a ton of, super reliable inflammatory markers there that you can be like, oh, treat this, right? Like it gives you an idea. But, something that we've heard at Precision too is people say, my knees and joints feel better. It's easier for me to get up and walk.
Is that because you're carrying less weight? Is it because you're carrying less weight, or because there's also something anti-inflammatory?
Right. And the other thing too is like, processed sugars, processed foods, things like that. If your body is processing those better, the inflammatory response that comes with those processed foods is significantly lower.
You may be right. Well. There may be an anti-inflammatory, but I'm not aware of any good data.
We're not talking scientific study, but we see patients, and when you hear a patient say something that's not necessarily in the literature, you want to kind of take account to it. Well, what is this doing for them that it could do for somebody else, right? Like
they're feeling a lot better.
Right, for sure.
They're looking better, they're feeling better.
For sure. And I think hunting down, inflammation and root causes is great medicine. And I think like GLPs really have the ability to do that. I kind of wanted to get back into cardiovascular health. So this is something that you've probably seen both ends of as an ER doc and working, at Lighthouse. The ER doc, you see people coming in with angina, strokes, all that huge cardiovascular risks that are life-altering potentially, versus now watching people lower their cardiovascular risk. I mean, and doing it effectively, you're keeping them out of the emergency room, essentially preventatively, right? So you went from treatment medicine to preventative medicine, which I think is super cool. And that's like what we're all about here at the podcast. What are some aspects or interesting things that you've seen, maybe getting patients that are heart attack risk or stroke risk, and maybe potentially lowering that for them?
Yeah, man, I see people on that day. Like yesterday, I sent a patient to emergency brain surgery for a horrible stroke. That's what I do as an ER doctor. But the longer, because of my age, and I just personally very interested in wellness and longevity. My personal opinion is that there really isn't a secret to that. It's the fundamentals. The fundamentals is what matters for that. So it's sleeping enough, having enough movement, quantity of food, quality of food, and then on the emotional side, how you handle stress and how much you invest in your personal relationships. So I think the age-old wisdom type of stuff is where it's at for wellness and longevity. These medications are a biohack on one portion of that. The weight, the consumption of food. This is a modern medicine biohack that supports one of the basic pillars of wellness.
Sure. So we've been talking about all the great things that happen with GLP-1s. Let's talk a little bit about the side effects. And sometimes side effects are good, right? When they were initially started, they help with type 2 diabetes, the side effect of weight loss. But let's talk about, maybe some of the more adverse side effects that people don't enjoy, and maybe some ways to kind of mitigate those, in prescribing and practice.
I'm glad you asked, because honestly, so my approach when I prescribe these medications is exactly that. I give all my patients free consultations, no commitment. And the purpose of it is education. Because what I find is that a lot of people peddling GLPs are very transactional and they don't take the time to cover this stuff. So I want prospective patients to know what I needed to know before I took them. And here it is. So first of all, yeah, they're amazing drugs. Let's look at first of all, contraindications, like who should not even be on these?
Absolutely.
And the answer is hardly any. It's very, very small. If you have basically an endocrine cancer, if you have thyroid cancer or something very rare you may never have heard of called multiple endocrine neoplasia syndrome, but these are endocrine drugs, meaning part of the endocrine system and hormones. So if you have a cancer in that type of organ, then you can't take these.
Right.
And I shouldn't take it. I mean, they're not FDA approved. I don't prescribe them for children. Like you're under 18.
Right.
If you're pregnant, you shouldn't be on these. But other than those things, that's basically it. Almost everybody is outside the contraindications. So if you clear the contraindications, then you really got to look at serious risks versus common side effects. In serious risks, and these don't get much press, so I'm glad you asked. There are really two, and they're quite rare. They occur in less than 1% of all the patients who take these medications, and they're pancreatitis and gallstones. Both of these things suck. You don't want them. And if you get them, you end up seeing a guy like me in the ER.
Right.
And they're temporary, you get through them. But, that is a risk. They're not without their risk. If you look at the risk of the just normal medications people take, compared to almost any medication for anything, we're talking about relatively rare, less than 1% for those two things. And that's really it for the bad things. Don't take it if you have endocrine cancers and, there's any chance you get pancreatitis or gallstones. By the way, sidebar, the gallstones, it's not because of the meds. The gallstones is because of the weight loss. Anybody who has significant weight loss has a risk of getting gallstones. If you have weight loss surgery and you lose a lot of weight, you have a risk of getting gallstones.
Got it.
Then beyond contraindications and rare serious risks, pancreatitis and gallstones, you have the common side effects. And they're common. They're really quite common. And they're generally no biggie. Those are GI symptoms. So patients have predominantly, the two main people have are nausea and constipation. And if we go back to the mechanism, we're talking about the mechanism, it makes sense. You have a fullness chemical, you're full, you eat, you might feel a little nauseous. And same with the constipation because it slows it through the entire GI system. So food takes longer in your colon where water is absorbed. So your stool gets a little drier. So constipation is pretty common. Most patients, both the literature and my personal experience prescribing over a year, has been that they're pretty mild and pretty tolerable. And most people don't even take anything for them. Maybe take a little Miralax or a little Metamucil for the constipation, maybe not. But most people are very high to trade minimal GI side effects for remarkable weight loss benefits and long-term health benefits.
So I had a question. What about the risks for gastroparesis? That's a side effect that I've heard that's associated with it. I mean, have you seen it as an ER doc, or is it like a rare symptom where somebody might overdose themselves?
That's BS.
Okay, fair enough.
Sorta. Okay. So there's a medical condition called gastroparesis. It's just a fancy medical term for your stomach's not empty. Like the stomach, it's just not. Put food in there, it doesn't empty.
Okay.
Classically, some diabetics will develop that. It's really a tough disease. I see the patients with that. And you could argue that this drug, one of its mechanisms of actions is medically induced gastroparesis.
Okay.
That's part of what it does. Now, the symptoms, the literature will tell us that 2 to 3% of patients on GLPs will have GI symptoms that are bothersome, including gastroparesis sign. I find it exceptionally rare that somebody will give up GLPs for GI symptoms. It's not zero, but in the end. So everybody is getting some degree of gastroparesis. That is how it works. Do we get patients that their stomach just fails and doesn't empty? No. The bad gastroparesis patients I see are all complications of diabetes.
Sure.
This is sort of a mild beneficial gastroparesis. But news articles are selling clickbait, so they sensationalize this and they don't present this in a balanced way. So I think that's a sensationalized fear that if you really understand how the drug works, you understand, some degree of stomach emptying, it's exactly what the drug is intending to do.
Right. And the only reason I say it is you see it. You see patients, we see patients, right? And I think this is a great episode of the podcast. We have the opportunity to educate people on these and what exactly they're doing. You know, a lot of people, just the general public, would be like, oh, I take this shot, I do this, whatever, I burn fat. And they are thinking, oh, I'm burning fat. This is some magic injection. And they might not really know what's going on.
It's not helping you burn fat.
Right. And I understand that. So, but some people, right, the common person maybe would say, well, if some is more, you know, some is good, more is better. Okay. And they end up injecting themselves with more. And I think that's where people more so run into.
I've not encountered people overdosing on it. But we should talk about dose response.
Sure.
Okay. And this I find that my patients really, people don't know this. Like this is an important point. So with GLPs, there is, whichever one you're taking, the more you take, the more it works until a point that it plateaus. So let's take the most effective one, tirzepatide. When you dose it, you start at a really tiny level. Like I call it a subtherapeutic dose. A dose that it's not really intended to be the one you're going to be on. It's really, you take this baby dose to check your side effects, how well you tolerate it.
See your response.
Yeah. How's your nausea? How's your constipation? And then you increase it to like what I would call the medium doses. So it starts at 2.5, and most people end up at, say, 5, 7.5. It goes all the way up to 15, from 2.5 to 15. The literature, and I'm talking about like really high quality, New England Journal of Medicine data on non-diabetics for weight loss, shows that 5 milligrams of tirzepatide gets somebody 15% total body weight loss. So if you take more, you can get up to a 20% body weight loss on 10 milligrams. But if you go from 10 to 15 milligrams, it doesn't continue to give you even more and more body. Like the difference between 10 milligrams and 15 milligrams is 1%.
Right.
So 20% body weight loss at 10, 21% at 15. That's why I don't recommend people going first of all, it's more expensive. You get almost no additional benefit, with rare exceptions. Like, I always want a custom solution for my patient. There are some patients who 15 will make sense, particularly very large people, like tall people. But the more you take, the more benefit you get, but it plateaus. So I think there's a natural incentive not to do that. I see that's actually a common misconception. I see all the time with patients with pain. They come in on NSAIDs, like they come in on Motrin, and asking how much they take, and they're like taking lots of pills. When you take the same thing, you take Motrin, you get some pain relief. You take more, you get more, but it plateaus.
Right.
And people, however, the pain benefit plateaus, but the side effect profile doesn't.
Right.
So people sometimes take too much of something, are risking a greater side effect profile without any additional benefit. And that's true. That's true of everything.
I mean, a statement that you hear patients say sometimes is like, oh, well, I take some, and if I take 2, it'll get me better twice as fast. No, that is not. No. You want to see a pharmacist cringe? Say that.
Yeah. There's another way. Here's another way of saying, I think we're saying the same thing, is it is good to do this in partnership with a good clinician, like like a real doc,
somebody who's going to follow you and work with you, for sure.
Yeah, somebody who can really help you with that stuff.
Sure. So something else I wanted to bring up, and this isn't necessarily a side effect, this is definitely preventable. But how about the muscle wasting?
Okay.
Right.
That's real. So there is significant research interest in the GLP development space on medications that'll be more muscle sparing. But with GLP weight loss comes some loss of muscle. It looks like it's about 3/4 of the weight you'll lose will be fat, and 1/4 will be muscle. There are ways to blunt that. And what I would advise anybody who wants to protect their muscle mass, and frankly, I think we all should, a whole nother conversation on the role of skeletal muscle and health. Fascinating stuff. You want to be able to pick up a suitcase, go up a staircase later in life. You want to preserve that muscle. So what do you got to do if you're losing weight on a GLP or dieting? You have to be deliberate in consuming lean protein regularly, every meal or most meals. And then you got to challenge those muscles a little bit. You got to do some things that, you got to push some weight around or do things that strain your muscles. You do those 2 things, you can blunt the muscle loss. You and I talked about there's interest in other hormone therapies. What about testosterone? But we really don't have any data on mixing testosterone and GLPs. But so no, I strongly recommend that if you're going to lose weight, weight with GLPs, get protein, push some weight around.
Right. And then, just being a pharmacist in the area, we see patients again, and we work with some clinics that do testosterone and tirzepatide, and there's a lot of benefit that the patients get. They're getting, weight loss from a couple different mechanisms. They feel better. They're going to the gym, and they're able to kind of put on that muscle. So it's almost like this really interesting reversal. It definitely has to be studied more to kind of understand dosing and, what the, I guess, protocols should be going forward.
Yeah.
But it's promising for guys who have felt horrible for years.
Yeah. Intriguing.
Yeah.
Yeah. I would just add a word of caution. Hormone replacement, in my opinion, as an MD, is actually really quite complex medicine.
It is.
And you definitely want to have a high quality physician assisting you with that. Because GLPs, like what happens, GLPs, the safety profile is much higher than it is with hormone replacements. I don't want to sound like I'm against testosterone. I'm for it.
Yeah.
But it's way more complicated. Testosterone requires monitoring, blood test monitoring. GLPs do not. Testosterone could have some long-term negative effects. That there are no known negative long-term effects with GLPs today.
There's a study that came out recently, I think within the last couple of days. I'll post the name of it in the bio. I don't remember it, but actually reduced cardiovascular risk with TRT. So,
Sure. Yeah, but it has potential long-term implications for fertility.
For sure.
There's prostate cancer risk has been looked at. I think that's been asked and answered. But yesterday I had a patient in the ER who was overdosing testosterone and that causes a reversible elevation of your red blood cells.
Mm-hmm.
His was actually the highest I've ever seen. He was a young guy. And he was at risk of like blood clots.
Wow.
So there is some money, there's some safety stuff around testosterone that I don't think you have around GLPs. Like if you want to do GLPs and not check your labs, I'm fine with that. I mean, if you do check your labs, you'll see your cholesterol improve, or see your hemoglobin improve, right? But you don't have to. Testosterone, you really have to be monitored. It's a whole nother level of expertise needed in it. But do I think it's an interesting concept? Yeah.
Yeah.
But if you're not going to, but you don't have to have testosterone to protect yourself from muscle weight loss. You can
for sure. This is definitely, like, we're talking high level, like clinical work at this point.
Yeah.
It sounds probably easy. Like, here's some testosterone, here's some tirzepatide. Definitely not. Kids, don't try this at home type stuff, right? But it is promising in the future, just for that there is a solution that is kind of coming out for guys. Now, we've talked a lot about the benefits, the side effects, some dosing. Let's talk about how to take them. So, and this conversation, I know, is going to kind of take some turns, right? So we'll talk about the injectables first. These are what have been out. But the last couple of days, there's pills. We can talk about potentially the bioavailability of Rybelsus and maybe how that works. And so now we have injectables. We have potentially a nice oral option coming out that's FDA for potentially, right? But let's talk about how to take it. I think injecting can be cumbersome for some people. Yeah. There's a way that you're supposed to inject medications that I think some people maybe skip some steps. But let's talk a little bit about that. How are you teaching your patients to take these meds?
All right. So the first thing I'd say is I totally get it. The reluctance to take a medication, I totally get it. And like I mean, it's like when you're going to inject yourself, it's like you're like, okay, 1, 2, 3. Okay, 1, 2, 3. Like I get that. I went through that, right? The truth is, we're using the tiniest needles known to man. They're the insulin needles. There's the patients who are taking insulin with diabetes, they're injecting themselves twice a day. We're talking about once a week. It really is painless or almost painless, almost always. But I understand the apprehension. And there's things, but the recommendation is to inject it in the fat around your belly button. You have some other options. Someone can hit you in the back of the arm in this little fat here, and you can do something in the thighs. But I do it around my belly button. Most people do it around the belly button. You just sort of pinch a roll around your belly button and you go in there. The needle's about the syringe is an insulin syringe. It holds 1 milliliter. It's tiny, and you do it once a week. There's a lot of things to do that you can do to minimize it. Even if you can do, for example, you can ice the area beforehand. They make these little tools that kind of you put on there, you vibrate them. You familiar with them?
I haven't seen those.
Yeah. Some pediatric ERs carry them for kids. You slap this thing on it. It goes like that. And then it kind of confuses your nervous signal and you don't feel it.
Oh, okay. That's cool.
Yeah, TENS unit for pain.
Yeah.
Kind of same concept. Okay. But most people don't bother with the ice or any of that. They just, after getting over their first shot, they're like, oh, yeah.
Just fire that thing in there.
That's the injection. So it's once a week. The original GLPs, the first GLPs that came out in the 1990s, they were twice a day.
Okay.
So the real science has been figuring out that
the sustainability of it.
Yeah.
And there are still some of the we'll call them alternative peptides. We won't say any names out there, but some of them are 3 injections a day.
Oh yeah.
Right. That, you know, your body metabolizes them. It's something maybe that it's a mimetic or something, and it will metabolize it the same way as, you know, your body would metabolize a GLP. It's in your system for 10 minutes. So some of these like alternative peptides do require a lot of injecting.
There's no doubt that when we get a pill version, the market will blow up.
I think,
you know, I'm reminded of Viagra.
Right.
I was in med school when that came out, and here's what people don't know: there was a very effective erectile dysfunction drug before Viagra. It wasn't injectable, but you had to inject it into your penis.
Right.
It worked. Well, how many guys do you think lined up for that, right?
Right.
Compared to when they came out with an effective pill, the market was elastic a lot, right? I think the same thing here. Like right now, the last thing I read from the last thing I read, actually, it was New York Times, was that 12% of American adults have tried GLPs. Well, I think that number is going to be a lot bigger when there's a pill. So
For sure.
let's talk about the pills.
Absolutely. Let's get into the pills.
Okay. So first of all, let's talk about what exists today and what's in the research pipeline. News came out this week about pills, which is really topical, but semaglutide is actually made as a pill in addition to a weight loss. Rybelsus. I don't prescribe it. And then tirzepatide is only injectable from FDA approval. So, okay, so let's look at what's approved for what and what's available for what. So for weight loss, you have those 2 major injectables are FDA approved for weight loss, and they're existing. The maker of semaglutide came out with the pill. They did not seek FDA approval to use it as a weight loss drug, even though they were selling. I mean, the sales of semaglutide when it first came out, it was Ozempic, made the company that discovered it the most valuable company in Europe. They went from like nothing to bigger than any other company in Europe on this on that one drug. So why aren't they offering that as a pill? Because it doesn't really work. The weight loss data on oral semaglutide on Rybelsus is 4%. People get 4% weight loss on it, compared to the injectable, where they get, in this case, semaglutide, on the highest dose semaglutide injectable, people get 15%. 15 versus 4%. So they made a business decision not to get FDA approval for weight loss, and people don't really use it for that.
Yeah, I mean, we see it in compounding. We see some people doing rapid dissolve tablets, especially before shortage med, and then, you know, compounding nerd stuff, shortage med, non-shortage med, all that. We've seen rapid dissolve tablet and different tries at it, right? And you just kind of start to realize that, you know, there are some routes. The sublingual is good. That's what I do personally. Injectable is probably the gold standard for sure. But you realize that an oral option for what we have right now available on the market isn't really reliable. The body recognizes it as, you know, the stomach recognizes it as food. It just dissolves, right?
Yes. Talking science, though, the only literature that I'm aware of on oral medications, oral GLPs, is the research data on Rybelsus and they showed a 4% weight loss.
Right.
Tirzepatide, they don't make that in the manufacturer, people develop, they don't make it as a pill. There are compounding pharmacies that will offer it as a pill, but what I can say is I know that the pill of semaglutide works not even a third as well as the shot, and I have zero data on any other GLP pills because they don't exist.
They don't exist.
It doesn't exist. So that's today. What's in the news that's got people excited? There was a news article last couple of days that raised the market cap of Eli Lilly by $100 billion in like a day. And what was it? It was that they had a clinical trial on a pill GLP on the GLP pill. All right, I don't want to butcher the name.
I've been trying to say this all morning. I've been trying to say it last night, just for everybody out there. And if you make fun of us, you go online and
you
say
it.
it.
You say it. Or forglipron.
Or forglipron. Oh, we're getting better.
All right. So that's not what that's not how they're going to trademark it, right? That's the scientific drug name. So what they released is they released a study that showed that there was 16 pounds of weight loss in 10 months. That's what it showed. And it got a lot of investors excited that this could be the first successful pill in this category. It's a challenge. So these pills are peptides. What does that mean? A peptide is just a small chain of amino acids. In other words, a piece of a protein. It's like a tiny little protein. And what we've found in science is that proteins don't survive the stomach very well. In the stomach, we're really good at breaking down proteins. That's what we do, right?
Right.
So they're struggling to do that. And here's one that, so it's been bioavailability, like how much of that gets through, how much isn't right. It is skipping the stomach with a shot where you're getting the better effects. But this pill showed 16 pounds. That's not nothing in 10 months. Some caveats. Number one, they released the results, not the data. So as of today, no independent third party has gone and looked at the research data.
Right.
Number two, well, I guess the other thing that's really topical is the patients on orforglipron were not having GI problems. Pfizer, kind of famously within the past couple of days as well, has pulled their pill. But Pfizer's trying to get in this market. They don't have a drug in the market right now on GLP, and their GLP pill got pulled a couple of days ago. They pulled it because their preliminary clinical trials were showing liver damage. And this pill, the one that just came out now,
Orforglipron,
didn't show liver, but it was on 560 patients, 559 or 58 patients. So sometimes you need larger patient sizes to really see the more rare issues. So on a small to medium sample size, they didn't show the problem that caused Pfizer to pull their drug. We haven't seen the data, just the study results. And lastly, this was a test on diabetics. So they were looking at the drug and how well it works. It's a diabetes drug. They're looking how well it works in diabetics, and they found that there was weight loss. It has not been studied on non-diabetics for weight loss. But I think here we can be cautious. We can be optimistic because when you look at the injectables, they work just as well in diabetics and non-diabetics.
right.
So it stands to reason that if they solve the viability problem, it will most likely have the same weight loss benefits in diabetics and non-diabetics. But to be fair, the study was, less than 600 patients on diabetics, 10 months, 16 pounds on average.
Sure. So we can kind of shift the conversation over to compounding a little bit.
Yeah.
That's like one of the areas that I'm involved in. It's somewhere you have experience in, probably as a prescriber.
As a shopper, I had to find a good compounding pharmacy. Yeah.
So we've been talking about the FDA-approved medications that come from the pharmacy manufacturers. Now, I'm not going to get into the nerdy aspects of it, of what makes a compounding pharmacy able to make it or not, because there's some differences. But basically, compounding pharmacies started picking these medications up, and we're making a ton of money and
they are
producing a lot
regulated.
of product.
They're regulated by the state.
Right.
Yeah.
And then, some of the bigger compounding pharmacies, they're even regulated by the FDA.
403B.
Yeah, 503Bs. And then, like us, 503A, we're regulated by Florida Board of Pharmacy. And so there is regulation there.
Mm-hmm.
You let everybody know. I mean, most pharmacies do have to pass inspections every couple of years. And so this isn't just the wild, wild west necessarily anymore. At times it has been, but there's a lot of...
You know better than I. I'm concerned it's the wild west.
Still?
You said you're a pharmacist,
right.
But definitely this is your turf. But I can tell you this, when I became interested in it, what I was reading was that there's a lot of gray market for these drugs, a lot of gray markets for all the blockbuster drugs, but including the GLPs. And like, who's making this? Is it, they really have what it says it has? Who's regulating it? Are they testing it? Like I didn't want to be involved with it,
right? If
it wasn't going to be top shelf,
right?
So I think the reputation of whoever you're doing business, who you're getting it from, becomes really important.
Sure. I mean, you have to do your research, and
yes.
I think if you look at compounding pharmacy right now versus compounding pharmacy 10 years ago, the amount of regulation that is on us now and compounding pharmacy, there are still, believe me, components of Wild Wild West, right? But it's significantly less.
No one had heard of compounding pharmacies until the GLPs, right? But they've been around forever. Like in a hospital, a lot of the medications that are given to hospitalized patients, antibiotics, they're compounding. Compounding's been around forever. It's a very legitimate side of medication. All it means is that you buy some raw materials and you mix and you dissolve them into yourself.
Right.
Like we even compound at the bedside. I had a patient yesterday who had a stroke and had to get a clot busting drug. That doesn't come pre-mixed. We mix at the bedside when we give it. It's kind of like compounding at the bedside. So compounding is a legitimate thing that's been around forever. But because the GLPs are so big and because there were some shady characters in that space, I think you need somebody who can assess the quality of the pharmacy and pick right.
Right.
Me personally, what I do is when I prescribe compounded GLPs, affordable compounded GLPs to patients, I only prescribe to my patients from the pharmacy that I'm taking. They're taking the medication I'm taking from my pharmacy.
Right. You know, a lot of pharmacies now, especially that do sterile, they have to do lot testing, batch testing, finger swab testing. So, you know, and they have to pass these regularly third parties. So I think there is a lot of safety protocols that have been put into compounding pharmacy.
So you think it's stabilized?
I think it has stabilized. Don't get me wrong. Like, you know, being in it, you still see some Wild Wild West things.
Don't buy it on the internet, right? from Joe.
Right. Well, and even if you do that too, I mean, you know, there's, if you really want to get wild, I mean, there's experimental only websites and you can.
Yeah, that's super sketchy.
I'm not going to get into that, but you can get anything you want off there and it can come from any pharmacy in the world. And I would say you're taking a massive risk with your life and health if you do that. You know, then the next step would be if you find a compounding pharmacy that you like, that you vet out.
But you don't have to.
Right.
The clinician or medical practice that you would be, if you're interested in this, go with a class act that is going to vet the pharmacy for you.
For sure. So I will say, like, it has changed quite a bit. And I think compounding, for the most part, is a really safe route to go where people can get affordable medications. Hey, if you can afford the name brand stuff, go for it. But I think compounding provides a great solution that has made these medications much more accessible to everyone.
Yeah.
Right. And seeing it as from a pharmacist perspective, especially if you're looking at someone like a patient on a fixed income with chronic diseases, these medications could change their life potentially. And, you know, they might not have been affordable at the time. And I know Medicare at times has said, we're not going to cover these, but being able to get it at a compounding pharmacy is good for those people who it saves them some money. They still get the benefit, you know, and I'm always rooting for compounding, right?
Yeah. Well, sounds like a good segue to talk about cost and price.
For sure.
All right. So amazing medications. Like a lot of people want to come on them. When they first came out, if you went to a pharmacy to buy a month's supply of the stuff, you're talking $1,400.
Right. Very expensive.
They projected that if the government were to cover this for everybody who qualified for it, it would literally, that the cost of medications would exceed the entire budget for all of healthcare. And insurance companies have really, some cover them, some put more stipulated. I think insurance companies have a strong incentive to try not to pay for them because the average person, if the person is on average with a medical plan for 4 years, so it's going to cost $15,000 a year for the insurance company to pay for those drugs, and the patient will have massive health benefits down the road when they're no longer.
Right.
So I think if you can get these covered by your insurance, man, awesome, good for you. Take advantage of it. The market dynamics is that the insurance companies don't really want to fork out.
For sure. In a way, like it incentivizes them, right? Ultimately, if patients get healthier, you potentially have to spend less on them, like on the big healthcare spending, but
that's down the road.
Right. And you don't even know if they're going to be with you. Right.
The short-term benefits are going to be your blood pressure will get better, your cholesterol will get better, your weight will get better, your hemoglobin C will get better. All the other stuff, decreased cardiovascular risk, stroke, dementia, kidney disease, diabetes, that's all for down the road. So they don't see that. The insurance companies don't see that. You do. So then people try to get compounded, the generic medication with something else added to it. Oftentimes, the compounding pharmacies will take the tirzepatide or the semaglutide, and they'll add things like vitamin B12 or L-carnitine or something else, so that they compound, they mix it together.
I think the big secret ingredient too is vitamin B5, and it's written in as a patient-specific medication to reduce nausea. That's the insider, workaround, I'll tell you. in our audience, they hear about insider stuff all the time, so they're not uncommon to it. But that's a, you know, kind of the workaround. Some patients like it, some people don't. They get the niacin flush sometimes, which can be uncomfortable.
Yeah, I felt
you know,
it. Yeah.
if you especially, it's like niacin flush. For those of you who don't know, if you take too much pre-workout, that's what that is.
Yeah.
That's how that feels.
Tingly and
yeah,
nauseous,
and you're just
yeah.
like, it goes away, but it's uncomfortable. So
so prices. So
Yeah.
you know, the prices for, depending on the compounder or the medical practice, it'll be anywhere in the $150 to $350 range, depending which GLP, what dose.
Sure.
So, you know, from over 1,000 to some fraction of that. You might even think about it as like, you know, there's a lot of ways to think about it. That's the price of the biohack for, but it's also, I think of it in a form as an insurance, you know, because of the future health benefits.
Sure. And, you know, sometimes it's good to have people invest money in it, right? You get some skin in the game, you're going to do better, you want better results. And then, I mean, that's just how I think of it. If you're invested in it, whether it's time, finance, whatever the investment might be, that skin in the game is going to generally, I feel like, help people stabilize and use it better, right? And so I wanted to say that because, you know, as we go from using it, I was at a trade show this past weekend and I saw a GLP-1 weight loss telehealth business right across from me. Their way to attract people was to put out candy on the table. And at some point in time during the day, they're breaking out Doritos and eating it. And like, I heard one of the people, like the reps at the show, say, "Oh yeah, man, I lost a bunch of weight. I eat whatever I want." And I was just like, "Oh man, this is bad medicine," but yeah, it's entertaining, right?
I go with someone maybe a little more ethical, a little more educated.
Sure.
Yeah.
They were professionals, but it just is what it is, neither here nor there. So what are some foods that you recommend to your patients? Like somebody comes to see you, they want to lose weight, and you're ready to go on this journey with them. This is just a tool in our health and wellness tool belt, right? Another potential, you know, we have exercise, which is another tool. Now let's talk about what are some dietary recommendations that you make. You know, we talked a little bit about, you know, supplementing with protein and things to keep the muscle mass on, but you do want to make that transition now into a healthier lifestyle.
I'll break the recommendations down into two categories.
Okay.
GLP specific recommendations and just like general nutritional advice. So people find that heavy foods, fatty foods, fried foods tend to trigger more nausea on GLPs.
Okay.
They alone will cut your total calorie consumption. So even if you don't change the type of food you eat, you're going to eat less food, you're going to lose weight. However, I mean, I don't think there's a real massive secret here. You want to eat healthy. It's the stuff we all know. It's just, you know, it's just the discipline to do it. But avoiding processed foods and, you know, eating the stuff on the edge of the supermarket, you know,
right.
The healthier stuff. So it's not just food quantity that's going to help you, but food quality. So I would say eat the healthy stuff, the Mediterranean diet, you know, lean protein stuff.
Right.
Yeah. Avoid the fatty stuff. Avoid the fried stuff.
Well, big aspect, like
avoid a lot of sugar.
Right. Going back to our conversation at lunch the other day, where we were talking about exercise and implementing an exercise program, doing something that you enjoy. When you're talking about GLP-1s, potentially, you know, you might be running into people who haven't really eaten a lot of fruits and vegetables in their life, right? Like they might have been predominantly raised on processed foods and things like that. I mean, what's the coaching process like, you know, shifting someone's mentality to that, where you're going to go with, you know, caloric, you know, less foods, but more nutrient rich. How are you helping people make the switch?
I think the biggest thing that we focus on here is that whole concept of a lifestyle reboot. Like, this tool is effective. It will help. So maybe you want to look at things from a bigger perspective. What else in your life do you want to reboot at the same time? Because it's going to give you that confidence, because it's going to give you some success. And I would say there, you know, you got to find what you like. So if you're not used to eating fruits and vegetables, you want to experiment with those, but avoid sugar, avoid fat, avoid fried, and then play around with the rest.
Right.
Get some protein, do some exercise. What I really enjoy is advising people on exercise, because I kind of have a unique perspective there. I was a college athlete. I've been a long life athlete. I still compete in several sports, and I've owned CrossFit gyms, and now I'm in the weight loss business, and I'm an MD. So I put all that together. Here's my personal opinion for anybody who's looking to add exercise or movement into their wellness journey, I would say focus on one thing above all else. Fun. Fun. Doesn't matter what you do. Just pick the thing that's the funnest, that you're going to enjoy, that if you don't get to do it that day, it bothers you. Because intention, discipline, they're fatigable. So I think people are most successful when they just go. So whether it's pickleball or martial arts or swimming or running or whatever, just think of the funnest thing you can possibly do and try that. And if that's not it, go to the next thing. So
do something and have fun. I mean, that's a great one.
For exercise.
Right.
I would just boil it down to that and not worry about anything else. And once you're in the habit, then you start branching out and trying other things. But if you need to get into it, go for fun.
Yep, that makes sense. So we talked for a little bit now, and you mentioned that you had a personal experience. You're a prescriber. You're also a patient.
Still am.
Still am. And so let's take the doc off the table for a second, if you can, as much as you can, right? What has your patient experience been like?
Oh, okay,
right? As
yeah.
a patient, and this can be opinion, right? We don't have to dive hard science here, but just let's take the doc off the table and say, like, what's your patient experience on GLP?
GLPs. For me, I call it the meh. So I hear people talk about food noise or whatnot. What I experience is that, and it's just like fascinating. So the first thing I experienced was nothing I tried worked. Like I tried a bunch of times, and I'm pretty driven, like I could go to the gym. I could work out an hour, 2 hours a day. That just wasn't doing it, man. After a certain age, that this doesn't, I mean, if you can do it on exercise alone, awesome. And I tried to eat well and mostly did. There was a sweet tooth at night, but when I got on the GLPs, what I experienced was I didn't have to finish the plate. If I'm eating and I get distracted, I don't know, text message or whatever it is, turn around to do, handle whatever my business is, and I turn back to my food without GLPs, I'd finish it. With GLPs, I look at the food and I go, It's not like I'm expending willpower to say, no, I will control my portion size. Is that you look at it, and I call it food indifference. People call it food noise. So I thought that was really kind of an interesting experience I never really had before. I found it with alcohol too, which has been shown to decrease drinking. The same thing, like someone offers me a beer, and I drink on the weekends, but someone offers me a now, and I'm like, So the mez, that's been sort of my experience. The other part of the experience was I had to take that box up in my closet with the pants that no longer fit, bring that puppy down, take those guys out, and not put the ones that no longer fit because they're too big, and stick them up in the closet. So that you look different. And I have to say, I really have liked that.
For sure. How do you feel like? Do you feel like you've gotten any better gains in the gym? Do you feel like it's helped you in the gym at all? Like
I'm a little more live, a little quicker.
Okay.
Yeah, I feel pretty young.
That's good. Any, like any of the benefits that we've talked about, like, do you feel like you've had decreased inflammation, decreased pain, things like that, just from an anecdotal perspective?
No, but I didn't really have pain, or if I have inflammation, I'm gonna, there's no marker for inflammation. I feel more spry, but I mean, I'm a pretty healthy guy. Personally, I'm pretty healthy. I don't have any medical problems. So
sure. And then I guess one other question is, have you taken any drug holidays from GLP?
Yes.
Okay.
Yes.
Let's talk about those.
The hunger comes back, man. The appetite comes back. The weight comes back. So the literature, what do I have for a second? My dog for a second. The literature shows that when you stop taking GLPs, people on average regain 2/3 of the weight they lost. Now, there are some strategies for that, but what I personally found, like it happened to me recently, I was I tore my meniscus snow skiing recently, and partially because I wasn't doing exercise anymore, and partially because I had to have surgery. Like before the surgical period, we didn't talk about this, but if you're going to have surgery, you probably want to get off the meds for a little while because of the stomach emptying thing. You want your stomach nice and empty before anesthesia. But so for a couple of reasons, I went off it for a month, 2 or 3 months ago. Yeah, man, I put on like 8 pounds in a month, and you can feel it. I personally can feel the difference between this dose, and this dose in terms of my appetite. In fact, sometimes I lose track of when my dosing date is, and I'll be at night, and I'll be eating a lot. I'll be like, I'm kind of hungry tonight. And I'm like, I missed my dose, or let's don't do tomorrow. Like,
right.
like even when I don't remember it's time, my appetite will come back. So I feel the difference a lot. For me, it's mostly at night. And the other thing that's interesting for me is that mornings, I'm just not hungry. Like I routinely don't eat before lunch or 2 p.m. because I'm just not hungry in the morning. I still have quite a bit of appetite at night, like I always did, maybe less. So I'm experiencing a really remarkable lack of appetite in the morning and a really beautiful meh around food. And certainly feeling the appetite come back towards the end of my week interval or whenever I stop. Yeah.
For sure. Well, Andre, it's been great talking to you. I think we've covered a lot. Is there anything that we missed or that you want to mention about Lighthouse Weight Loss, your career, your personal experiences, any of that we have not covered?
Well, I appreciate the opportunity.
Sure.
The little promo for my business.
It's been a pleasure, man. It's been awesome. And I know that, in talking to you at lunch, talking to you today, you care about your patients, you care about their success. And, that's something that we don't get every day in medicine.
I really want well-educated patients. I've spent an entire career, like over 25 years educating patients, just applying it to GLP. So thank you for the opportunity to talk about our business. So I'll just tell you what I think is different about how we do it, how I do it. Number one, it's all telemedicine, so at your convenience. Number two, the meds are shipped directly to your home. Really fast order fulfillment. If you decide to place an order, you get it. It ships that day or next business day. Number three, you'd be having a prescriber who's on them themselves. You'd be taking the same medication most likely that I'm taking from my pharmacy. I think that goes a long way towards trust.
Yeah, for sure.
Number four is we have a real simple, transparent business model. A lot of companies out there are selling GLPs kind of like airplane seats are sold, where they false advertise as low as, and then you have to sign a contract. We don't do contracts. You have to do a subscription. We don't do subscriptions. Or you have to pay for the provider's appointment. We don't charge anything but for the medications. So the initial consultation, if you're interested in talking to us, it's free. Any time you have a question, you can book a telemedicine appointment. We don't charge for that. We make our profit on the difference between what it costs us to buy the compounded GLP and the price. And we try to keep it really simple. You reorder when you're ready. And then lastly, I really want a custom solution for each person, because everybody has different experience. So, if you need help with nausea, great, we'll help you with nausea. If you need whatever you need help with, I view it as I want to be a guide on a wellness journey. That's why we picked the term Lighthouse.
Okay.
We want to be your weight loss and wellness guide, and that's how we roll.
That's awesome. On my personal business website, I have a Lighthouse.
Yeah. Yeah. What do you know?
Yeah.
Good metaphor.
Medication management, healthcare guidance, solutions, all that good stuff. So the Lighthouse is super important. One thing that you kind of said is really important if you're looking for a GLP program as a person, patient, whatever. I think it's so important that you roll in kind of the price of it with the medications, but you have a prescriber or doctor that's monitoring you. If somebody has an issue, they can contact you. They can help them through it, right? And you have a support system who is medically trained, also a patient, has probably felt the things that you're feeling and going through the same way. And I think like finding somebody who has, that experience all rolled into this wellness journey that you're about to help somebody go on is invaluable to their experience on a wellness journey.
Yeah, I mean, to be honest with you, most of my patients need very little help, but when they do, I want them to succeed.
Sometimes it's just nice knowing, even if you don't need the help, someone's there and they got your back, and that in itself feels good, rather than like airplane mode, weight loss or GLPs, airplane GLPs. You order it, you fill out a form online, some pharmacy fulfills it and sends it to you. Who are you talking to?
Yeah,
who can answer your questions?
It can be pretty transactional. We want custom solutions and support for the journey.
Andre, it's been great having you on the show. Thank you so much. You are welcome on the Men's Health Unscripted podcast anytime. Thank you so much.
Good talking with you.